Good evening,
Estamos apenas
Ritu.
comenzando.
Hello, my friend. It's nice to see you.
Can you hear me?
Okay.
Yes.
Yes, we hear you perfectly.
Okay.
Bien, buenas noches. Primero queremos avisarles que tenemos traductora simultánea para los que necesiten. En la parte de abajo de la pantalla donde dice, como hay como una figura como un mundo y dice interpretación, por favor apaguen los videos, apaguen los audios. ¿Quién tiene abierto el micrófono? Bueno, entonces cuando ustedes le dan clic en donde dice interpretación, aparece o inglés o español. Entonces ustedes le dan sobre español y escucharán la charla, la interpretación que nos da Cristina, nuestra traductora. Recordamos entonces, por favor, mantener apagados el vídeo y el audio y les agradecemos nuevamente la asistencia a estos eventos académicos que organizamos mensualmente en la Asociación Colombiana de Ginecólogos Oncólogos junto con la Junta Directiva. Hoy tenemos una invitada de lujo, la doctora Ritu Salani, que es la directora del programa de Gineco-Oncología de la Universidad de UCLA, quien nos hablará sobre un tema muy interesante, el seguimiento de las pacientes después del tratamiento de cáncer ginecológico. Tema que seguramente dará para muchas preguntas al final sobre los esquemas que actualmente estamos utilizando. En las preguntas entonces quedarán al final. El doctor René Pareja será nuestro moderador y quien hará la presentación oficial de nuestra invitada, la doctora Ritu. René.
Gracias, doctora Lucrecia. Ritu, thank you so much for accepting our invitation tonight.
This is my pleasure. Thank you for having me.
We have now more than 60 people connected from all along Latin America.
This is
I'd like
exciting.
to introduce Dr. Ritu Salani, who is a professor of obstetrics and gynecology and the division director of gynecologic oncology at UCLA in California. Her clinical interests span the care of women with gynecologic malignancies, as well as post-treatment care. She received her undergraduate degree from Kent State University and her medical degree from Northeast Ohio Medical University. She completed her residence in gynecology and obstetrics at Emory University and her fellowship in gynecologic oncology at Johns Hopkins University. She also received her MBA from the Carey Business School at Johns Hopkins University. Her main research interest is in novel therapeutics for cervical cancer. She's been the principal investigator on national and international clinical trials evaluating the role of new treatments in advanced cervical cancer. She also serves as the co-chair for the International Cancer Institute Cervical Task Force Committee and is an active member of the NRG Oncology Service Committee and National Comprehensive Cancer Network in Cervical and Uterine Cancer Guidelines Panel. She has published more than 100 papers. Dr. Salani is a dedicated educator and has served as a mentor to trainees and junior faculty. She has been recognized with multiple teaching awards through her career. Additionally, she has served on the education committee for several professional organizations and is currently the chair of education for the International Gynecological Cancer Society, and since September will be our treasurer. So it is a big honor having you, Ritu. So please start your presentation and thank you so much again.
Well, thank you for that very kind introduction. Give me 1 second to share and I'll make sure everything is visible to everyone. Good?
Yeah.
Okay. Well, it's really a pleasure to be here. My only regret is that I'm not there in person because I would love to see you all and be in Colombia, but I'm so honored to be asked and by Renee, one of my good friends and colleagues who I've learned a lot from. This is a topic I'm very passionate about changing practice and talking about post-treatment cancer surveillance. We know that this is something that there's not a lot of data on, so I'm going to share with you what we do know. And as you heard, I do have my MBA, and so one of my interests is also in cost savings or opportunities for cost improvement in medical practice. These are my disclosures. And today, really, I hope to review the surveillance needs of cancer survivors, why this is important, discussing the post-treatment surveillance practices that currently are in play and how we can impact those. What is the impact of this on cost? And then really, what are challenges with changing practices? Why are so many people so resistant to change current practice? And so I want to start just with gynecologic cancer survivorship. And I apologize, many of these numbers are based out of the United States. I did look at Colombia numbers, but most of the papers were in Spanish, so I was a little bit out of my area. So forgive me, but I hope this will translate well. Currently in the United States, we have over 8 million women who are cancer survivors, and about almost 1.5 million are gynecologic cancer survivors. And as you can see from this graph, between 2019 and 2030, we expect about a 30% increase in the rate of survivorship. And so more women are surviving with cancer. We need to learn how to manage these patients and for how long. And so really my goal is to discuss what are the best surveillance practices for recurrence detection. But before we talk about this, I want to just review some antiquated medical practice. So some of you may be familiar with the theory of humors, that we have these liquids in our bodies, and they are the kind of the root of all imbalances, are the root of all diseases. And this led to the practice of bloodletting. This began in the 1st century and was actually used as recently as the late 19th century. And physicians or providers used it for all different types of medical ailments without really any study or research behind it. And really, there was no known benefit to this practice. It did lead to significant complications. And one of the important things to recognize is, George Washington, our first president here in the United States, actually died from bloodletting that was being used to treat epiglottitis. So kind of, there are complications of some of these practices that we use. So let's go to surveillance. And when you look at the history of surveillance, one of the first papers that was published that I could find that was pretty standardized was in 1992. And this was a survey study of all gynecologic oncologists in the United States. And there was about 100 gynecologic oncologists who responded to the survey. They asked about all cancer types and stages, and they asked kind of the frequency of visits and what testing were done and what other practice habits were enforced. 100% of gynecologic oncologists said we do visits every 3 months for the first year, regardless of the cancer type or the cancer stage. 84% did Pap test at each visit, and 76% did imaging for the first 2 years. And this was really just based on kind of what they knew and what they thought was best for our patients. And so this became a research interest of mine when I was a fellow, because we had such variations in practices. One of my faculty members would do one thing and another faculty member would do another thing. And so I thought it would be interesting to evaluate this further. So I looked at the variations in practice. I wanted to kind of look at what was low quality care and what was high cost care that could be eliminated. And I also wanted to see what the impact was on survival, because there really wasn't any great data on this. So I had the opportunity to work with the Society of Gynecologic Oncology and publish our guidelines on post-treatment surveillance. And I'm going to review how we came to that. The first paper we published was in 2011. And I will say the first time I gave this talk to today, there's been lots of revisions on this, because this is a continual area of investigation. And I think that's a really important thing. So I want to start by first talking about surveillance goals. We know that our goals of anything we do after treatment and including treatment should impact survival outcomes. And we want this to decrease morbidity for all of our patients. We also want to make sure that we're balancing any intervention with possible pitfalls. For example, oftentimes when we do something, there may be some psychological impact on patients if there's not even other high risk, like medical risk, such as the contrast dye from CT scans, or blood tests, which may have false positives and result in unnecessary interventions. We want our therapies to remain cost effective. Doing scans, every 3 months, is that really beneficial? And what does that translate to? And how do we kind of strategize the best practices to be cost effective? And then on top of everything, we want it to be clinically effective. If we order a test and it shows something, how does that impact survival? How does that help us determine what we do next? So I'm going to go by each disease site and review each disease site and their surveillance practices, focusing on cervix, endometrial, and ovarian cancer. So worldwide, there are over 600,000 new cases of cervical cancer and over 300,000 deaths. So we know this has quite the global impact. When we look at the data and you look at studies, kind of universally, you see that most recurrences, just over 50%, occur within that first 2 years. But we know advanced diseases that can occur even earlier, and they have higher recurrence rates. So patients with lower stage disease have lower recurrence rates, and that may be even further delayed. So I want to start with cytology. Cytology is such an important metric for cervical cancer screening, but I want to explore the role it plays in post-cancer treatment surveillance. And so when you look at cytology, there are lots of studies that have done this, and we see abnormal cytology in about 0 to 17% of patients once they've had cervical cancer treatment, but it's rarely an isolated finding. So even in those patients where it's, maybe a fifth of patients have abnormal cytology, it's rarely an abnormal finding where it's usually associated with symptoms or something else. The other thing that you see with cervical cancer surveillance with cytology is that most of the changes are low grade. And so this is in predominantly a group of patients who've had surgery only. And when you see low grade changes, we get very nervous about that. This patient's had cancer. We're worried about now vaginal cancer. It often leads to colposcopy and additional biopsies. And many of these are unnecessary. And I apologize, I think I dropped the slide here, but one of the things that you can see is that the low grade are the most common changes, and it's about 60 to 70%. Oftentimes, you will also see ascus or atypical changes, which are oftentimes inconsequential. And so this often leads to unnecessary changes. What's worse is in patients who've had prior radiation, abnormal cytology may be present in 34%, but almost all of these are benign or mild changes, meaning low-grade changes, in the absence of other findings. And so we're giving our cytologists or pathologists a lot of extra work to look at this. I think it's always important if we do obtain cytology that we let our cytologists know this patient had prior radiation, so that can help them interpret the cytology. And so continuing on cytology, what about after radical trachelectomy? The patient's had her cervix removed. And we know that after radical trachelectomy, recurrence rates can be about 10%, right? And so this was a small study of just 41 patients who had radical trachelectomy, and they looked at patients who had at least one abnormal pap test. They looked at patients who had at least one pap test following the trachelectomy. And of these, 24 patients, or 59%, had at least one abnormal pap test. And you can see of total, there were 238 pap tests that were performed, and only 44 were abnormal. So that 18%, which is pretty close to what we see after surgery. Interestingly, they found no recurrences in their entire population, although I will note that one patient did undergo a hysterectomy for adenocarcinoma in situ, so that was probably a very warranted result. But they did conclude that there's limited role of cytology. And once again, it resulted in 7 patients, not a huge number, but 7 patients who underwent colposcopy and biopsies without further need. And so I think this is an important thing to recognize, that there is a very limited role of cytology in patients who had radical trachelectomy. The one exception is that patient with adenocarcinoma in situ who did have adenocarcinoma on her of her cervix, and that's why she underwent the trachelectomy. So I think this helps us inform us that cytology may not be the most meaningful in this setting. Well, what about HPV testing? So this was a study I actually participated in with some of my colleagues here at UCLA. We looked at 262 patients who had cervical cancer, and 58 of these patients were diagnosed with recurrence. So this was 22%. 169 of these patients had high-risk HPV testing in the surveillance period, and 24% of the entire cohort had positive high-risk HPV testing, and 14% of this cohort had recurrent disease. When we looked at the recurrences specifically, only 5 of 41 patients had recurrence and were positive for high-risk HPV. And as you can see from the bottom line here, none of the cancers were actually detected by high-risk HPV testing. What was actually more notable is that 24% of patients who did not recur also had positive high-risk HPV. And once again, this led to unnecessary interventions such as colposcopy or even biopsies. And so we actually kind of felt that this was limited usefulness. And so this is something that we would not advise to do in the setting of surveillance for patients with cervical cancer. And so now I'm going to shift to imaging. So routine chest x-rays and CT scans have always had a low rate of detection for cancer recurrences. And really, there's been no shown benefit for survival outcomes when you look at the whole series. I think what's happening now is PET-CT scans are being useful in diagnosis, and oftentimes we use it in certain settings for recurrence evaluation. We know it has a high sensitivity and a high specificity. And probably one of the more studied areas is the prognostic significance of a PET-CT scan at 3 months in high-risk patients, those with locally advanced disease who've had chemoradiation, or those who had surgery and then followed by chemoradiation. And in those patients, PET-CT scan can offer prognostic significance and let us know who are potentially at high risk for recurrence or persistent disease, where we may have interventions. Outside of that 3-month kind of assessment, PET-CT scans in asymptomatic patients has never been shown to have any benefit. And as a matter of fact, it was shown to be not cost effective for routine use. However, it may play a significant role when recurrence is suspected, and it may play a role when recurrence has been diagnosed in determining which patients may be best candidates for exenterations. So I'm not saying there's no role for PET-CT scans. I think we just have to be very mindful about where we're using it. I do personally use it at that 3-month mark. And although there's limited data, it's, I think it's still a helpful guidance, but I don't use it after that unless there's a clinical indication. And so kind of in summary, limit, if cytology is going to be used, limit it once a year at maximum. That original study that I showed you where it was done every 3 months, or multiple times in a year, really doesn't have any validity, and I think it could be potentially harmful. There is really not a clear role for cytology after radiation or after trachelectomy, so I think this should be an individual discussion and decision making with that patient. I do think there's limited value of HPV testing. I haven't seen any data on ctDNA or circulating tumor DNA or HPV DNA. So I think this is an exciting area that may have some avenue in the future, but right now we just don't have any data on that. And I think it's really important that we reserve colposcopy for high-grade changes. Even in patients who've had cancer, low-grade changes are oftentimes inconsequential and can just be observed and monitored. In the absence of any other findings, these are likely going to resolve or be self-limited. However, I do think it's so critical that we continue to perform good, thorough examinations of the entire lower genital tract with visual inspection and speculum examinations. We know these patients are at increased risk for other HPV-related diseases. And I feel strongly that we should reserve imaging for clinical indications outside of that 3-month PET-CT scans for those locally advanced cervical cancer patients. So next, I'm going to shift to endometrial cancer. And here you can see that there are over 400,000 new cases each year in the world and almost 100,000 deaths. We know in the United States, these rates are actually increasing. And about a majority of patients are caught at early stages, but we're seeing higher risk histologies and poorer outcomes with these patients. For endometrial cancer, a majority actually occur within 2 years, with almost a higher rate, about 90% recurring within 3 years. And same kind of mantra here. Higher risk patients, those with advanced stage, high risk histologies, have a higher risk of recurrence and an earlier risk of recurrence developing. And so we know that most endometrial cancer patients have symptoms at the time of recurrence. Vaginal bleeding is by far the most common symptom of recurrence, but pelvic pain is also commonly seen. When we do physical examinations, we know that can also add to the detection of endometrial cancer recurrences, but most patients where you have abnormal finding on physical examination, they do have some symptoms. There was just a study presented this year at SGO, our Society of Gynecologic Oncology, where they actually noted they were actually advocating against physical examinations, but they actually commented that asymptomatic examination detected 14% of recurrences in patients with low-risk disease. And that to me is kind of significant because these are patients that are likely salvageable. So the patients most amenable or successfully treated with with radiation therapy. So I do actually think physical examination is a very important part of surveillance. It's also very low risk and low cost. But I do think in some patients, telehealth may be an option for patients who are traveling far. And in the day and age of COVID, this has really revolutionized the way we take care of patients. So making sure patients understand what symptoms to look for, and that can be complemented with physical examination. So this is one of my favorite topics, is cytology and endometrial cancer. This is a list of studies that really looked at the role of vaginal cytology after hysterectomy for patients with endometrial cancer. And you can see some of these studies are quite sizable. And you can see the recurrence rate ranges from kind of the low single digits to kind of the high teens. And this is kind of a variety of endometrial cancer types and stages. So the recurrence rate kind of varies depending on what the cohort was. But what I really want to highlight here is cytology alone picked up very, very few endometrial cancer recurrences. So it's not zero, but it's pretty darn close to zero. And so I would actually argue that cytology should be eliminated for the surveillance of endometrial cancer. And this last study, the 2022, I'm going to spend some more time talking about. Cytology also has significant costs. So we often think that Pap testing or vaginal cervical cytology is low cost, but it does add up. So we did a cost evaluation at single institution. And if you look at stage 1A, grade 1 with no invasion, that's a pretty limited group. At one institution, you can eliminate about $8,000 per year. If you apply that to every institution, that can actually add up, and that's based in the United States dollars. There was another study that looked at stage 1 to stage 2 disease, and they found that per the use of cytology per case of recurrence that was detected, you're looking at a cost of $27,000 to $44,000. And reduction of Pap testing can actually result in a cost saving of over $58,000. And if you do all of the uterine cancer patients diagnosed in the United States and eliminate yearly cytology for these patients, you can actually save almost $4 million per year. And so I think this is really important to recognize as we're kind of getting in a place where healthcare spending and costs are becoming unsustainable. These low quality measures that are still being performed need to be eliminated. Now, imaging for endometrial cancer. There have been a wide variety of different modalities that have been studied: ultrasound, CT scans, MRI, and PET CT scans. Kind of across the board, the recurrence rates for early stage are low. It's 3%, in low risk and 14% in these high risk populations. And in advanced stages, it's, about 50%. But across the board, asymptomatic recurrence detection is low. And we actually, based on this data, decided that recommending routine imaging is not advised. Now, if you look at some studies that look at asymptomatic versus symptomatic recurrences, they may show better survival in those patients who had asymptomatic recurrences. But when you take out that lead time bias, there's actually no difference in survival for the most part. These are also retrospective studies, so we have to take them in context. So this brings me to that study I was mentioning early. So this is the TOTEM trial. This was just published, I believe, a couple of weeks ago, but this was presented last year at ASCO. And this was actually one of the only prospective trials in gynecologic cancer focusing on surveillance. And what they noted is we actually already do intense follow-up for our patients, and there's no evidence for it. And so they performed this prospective trial looking at this intensive and minimalist surveillance protocol. And this is a study of about 1,800 patients, or over 1,800 patients. And you can see it's split 50-50. They had two groups that they looked at. There's a low risk group, which is truly low risk, stage 1A, grade 1 and 2. And then they had a high risk group, which was stage 1A, grade 3, or anything stage 1B or higher. And you can see the breakdown at the bottom of this, that most of these patients were stage 1B or stage 2 to 4 non-endometrioid histologies. And about 30% of these patients received chemotherapy or adjuvant therapy. So it's not the highest risk group, but there is a cohort of patients in this study that do qualify as those high risk, high stage patients. And so here's like a breakdown of what they randomized these patients to. So the low risk group in the intensive subset, they had clinical examination, as you can see, every 4 months, Pap tests once yearly, and CT scans of the chest, abdomen, pelvis yearly for the first 2 years. In the minimalist group, just physical examinations, 6 months, 12 months, and then kind of spread out over time. Now, the authors did allow for additional evaluation in the setting of clinical suspicion, or if there were abnormal findings on clinical examination or any of the tests that were performed. The high-risk group looked at patients in a little bit of different way. So they looked at patients, the screening here for the minimalist group was clinical examination and CT scans for the first 2 years yearly. And then you can see what's highlighted here in yellow are the differences where they actually looked at CA-125, abdominal and vaginal ultrasound and Pap testing for these patients, along with clinical examination and CT scans. And this was really powerful data. They show their overall survival, and your eyes are not tricking you. These lines almost totally overlap. There was almost no difference in these populations. Those who underwent intense surveillance had a survival of 90.6% and 91.9% for those with minimal surveillance. When you look at the low risk group and the high risk group, you see that same trend. Really, the overall survival was higher in the low risk group, not surprisingly, at 95%, and 85% for the total group in the high risk. But those lines completely overlap, showing no difference between intense and minimal surveillance. So really kind of showing that CT scans, Pap testing, and CA-125 have very limited value. They also did analysis of their relapse-free survival, and they noted that the median time to relapse was 14 months, so kind of within that 2 years. And 23 months in the low risk group and 12 months in that high risk group, which is consistent with what you see in retrospective studies. And when you look at relapse-free survival, actually very similar numbers. The high risk, the intense and the minimalist groups did almost exactly the same, as you can see from these survival curves. And so their kind of final statement or conclusions were really intensivist surveillance practices add no value to these patients. And really we should be doing minimalist strategies, because these do not, doing more testing just adds to cost, anxiety, and is resource intensive. And so this was a pretty cool study that was published in 2016, and they looked at the cost or the impact of endometrial cancer surveillance. So this was a database analysis, and they looked at early stage endometrial cancer patients. And they noted that in 2011, the number of cytology that was being performed was 66% of cases, which is just heartbreaking to me, because we know that this doesn't impact it. And what they found was CT scans were actually quite common in 1992 at 11%, at least once a year. And in 2011, it actually increased to 25%. And remember, this is in the complete absence of data. So then they did further analysis, and they said, well, what's the mean cost per patient? And they said, let's just say cytology across the board is about $63 per examination, and CT scan is $750. Just one Pap test and one CT scan in every uterine cancer patient in the United States is $50 million. So this is a huge tax on healthcare without any shown benefit. And now we have, just as of this year, we have prospective data that helps confirm that. And so I just want to take a little bit of a step away and talk about high-risk histology, because this isn't the majority of the groups that are evaluated. These are two studies that looked particularly at surveillance in these populations. And you can see they're not huge studies, but fair numbers of patients, and they are retrospective. Most of these patients had distant recurrence. So you can see cytology, not surprisingly, was very low rate of detection for recurrence. They did find that symptoms and examination were the most significant finders of recurrence in both cases. Imaging about 15%, and CA-125 when used in about a quarter or 10% of patients. These are two complete separate studies and very similar numbers. But what they found is that no matter what you use, there was no difference in survival, and really just recommending kind of your best practices. I don't think CA-125 is a bad thing to use in patients if it's elevated at the time, but I don't routinely get it. Oftentimes it's done when, you're distinguishing between ovarian or uterine cancer. But I think for an early stage serous cancer of the uterus, it probably has low value. And so I don't usually test it at that, but there's not a lot of data to support one practice or another. And so for endometrial cancer, kind of our recommendations are symptom assessment is really important, and we should advise our patients on what symptoms to assess for. Physical examination is of limited value, but it may be able to detect those that are salvageable. So I do think it's still important. I feel very strongly that cytology is not informative and it should be completely eliminated. And then CA-125 can be considered, but it has we have limited data on its impact on survival. And then once again, imaging should be reserved for clinical suspicion. And we now have prospective data that helps support that recommendation. And then the last cancer I want to focus on is ovarian cancer. And so there are 300,000 new cases in the world per year, and deaths about 200,000. Both the incidence and the death rate are decreasing in the United States, and this is probably in part due to better surveillance practices or risk-reducing strategies and better therapeutics that we now have. But we know that when patients are diagnosed, most are diagnosed in advanced stages, and recurrence is common. In early stages, recurrence can be as high as 10 to 30%, and advanced stages is generally about 80%, as high as 100%. And most occur within 2 years. And so kind of across the board with cervix, endometrial, and ovarian, we're seeing recurrences in that first 2-year period. Oh, excuse me, I think I went backwards there. And so when we look at surveillance, we first looked at symptoms and physical examination, kind of being the very most accessible, low risk, low cost tools. When patients recur with ovarian cancer, about 50% have symptoms. The symptoms, once again, are very similarly vague as they are at the time of diagnosis, but are very similar. So bloating, pain, and then GI symptoms. Physical examination really varies. 30 to 50% of patients may have findings on physical examination. If they have pelvic disease, that rate may be higher because we may actually feel it on pelvic examination, but most commonly it's abdominal distension that we notice. There are limitations with physical examination. We can't assess nodal assessment. We can't assess peritoneal disease, small peritoneal carcinomatosis, and upper abdominal disease may be limited. But because symptoms are a large part of recurrence, telehealth may be an option for these patients as well. And so let's start with CA-125 levels for surveillance. So, in 2010, this was a big study that got a lot of press, a European study that looked at about 530 patients with ovarian cancer, and they randomized patients based on rising CA-125 level versus delay to treatment. And what they found is that there was no difference in survival if patients were treated based on CA-125 level versus delaying until symptoms. And imaging was not part of this. And so what they found is that the survival was about two years across the board. So they questioned the finding of the role of CA-125 level. And after the study was published, the European Society actually recommended that CA-125 should only be obtained at the time of relapse and be used as a marker of response to treatment, or if the patient requested it. Now, there were some issues with this study. First, treating a patient based on CA-125 level only resulted in treating patients for a longer period of time. So patients had probably a detriment in their quality of life. But we know that CA-125 often rises before we see clinical evidence of disease. So I would argue that maybe we don't treat patients based on a rising CA-125 level, but maybe we kind of give them a better assessment of what symptoms to monitor for, giving them heightened awareness, or maybe monitoring them a little bit closer in that time frame, because it's probably only a matter of time before they truly will have a recurrence. And so imaging continues to kind of plague us with ovarian cancer. Once again, similarly to endometrial cancer, CT scans, MRIs, ultrasounds, and PET CT scans have been evaluated, and you can see the sensitivities and specificities for each of these in ovarian cancer. And kind of across the board, it really doesn't have great applicability to detecting ovarian cancer recurrences in the absence of symptoms or an elevated CA-125 level. And so really, we kind of just decided that CT scans or imaging is best reserved for patients who have suspected recurrences. And so here's another kind of couple studies that looked at imaging, particularly in ovarian cancer patients. And in two separate series here, you can see that 80% of patients had recurrence in the first series, and the detection method was most commonly CA-125 or CA-125 and imaging. However, this study did not look at symptoms, and they said that no matter how the patient was detected with recurrence, there was no survival difference. The second study found that concordance between CA-125 and imaging was only 43%. They did not report symptoms or examination that led to recurrence. And they just said CA-125 or imaging, it didn't really make a difference in survival. So not really the most informative studies, but just kind of showing us that we still really need to make a difference in survival. And this is probably more of a testament of us needing better therapeutics than anything else. So this is a prospective study, kind of ancillary study of a prospective study. So this was Payola 1, where they looked at bevacizumab and olaparib versus bevacizumab as maintenance. But they did this really cool analysis where they looked at a progression based on CA-125 level and imaging particularly. They did break it up into different subtypes, but I just want to kind of give you the kind of key data here, which is when they looked at CA-125 levels and imaging, you can see in this bar graph on how they detected the recurrences. And so what's highlighted in this light purple at the very bottom of the bar graphs are those patients who were detected by imaging alone. And so you can see in patients who had an abnormal CA-125 level, the imaging only picked up about 16 or 17% of patients who had recurrence. CA-125 picked up the remainder of those patients either by itself or in conjunction with imaging. So I think this is another testament that, CA-125 is a lower risk intervention, both on the healthcare and for the patient. And it's also less resource intensive. It's just a lab versus getting a patient scheduled with radiology. And so CA-125 in those patients who have abnormal CA-125 at diagnosis is actually probably the better tool to use for these patients. However, in patients who had a normal CA-125, you can see that about 44% of patients were diagnosed with rhesus. And I always take issue, why are we checking a CA-125 in patients who had normal CA-125s? I think the value of that is limited. So I think in patients who had normal baseline CA-125 level, the CA-125 probably isn't that useful altogether. It's probably more a reflection of peritoneal disease and actually tumor secretion of CA-125. So I think this is kind of a cool test study that looks at this. You can see on the right side, they looked at this based on BRCA mutation or BRCA wild type. And you can kind of see the similar trends based on what the CA-125 level was at the time. And so this study, they really argued for CA-125 levels being used as that primary measure and reserving imaging if CA-125 were elevated or if CA-125 weren't a marker. They did not look at symptoms. They did not look at examination. So you have to qualify it. But I think it just reminds us that CA-125 is a useful tool in certain patients. So that's kind of my overview of the data in our gynecologic cancers. But I wanted to kind of review how this impacts practice. So this was a multi-institutional prospective analysis done in the United States, and they wanted to look at practice before and after 2009. And they found about 1,200 ovarian cancer patients post-treatment who were included in this analysis. And what they found was that CA-125 was consistently used in patients at about 86% before 2009, and then about 90% after 2009. And CT scans also 81% before and 78% afterwards. And this is kind of just as routine surveillance. So really kind of not a huge change in practice, despite some of this data. Now, our surveillance guidelines that we published didn't come out till 2011. So what impact that would have now might be a little bit different, but we still see a lot of CT scan use to this day. What was interesting to note is that when they looked at patients who had a normal CA-125 at diagnosis, 94% of those patients continued to get CA-125. So it might just be that we get kind of into this habit, or our practices are just more habitual than actually thoughtful. And so it's maybe a reminder to just say we eliminate CA-125 in those patients. What was really kind of, I think, eye-opening to me is that 1/3 of the patients that they analyzed had multiple scans per year for routine surveillance. And so we haven't even been able to demonstrate the benefit of imaging once a year, but many of these patients had it multiple times a year. And so this had a limited change in surveillance practice. And when they also looked at cost breakdown, if you look at the cost per patient per year, it's about $1,056. And that is looking at CA-125 levels done every 3 months, so 4 per year, and then 1 scan per year. So that's $1,056. If you look at this across the board, if you say, let's take all the patients with ovarian cancer diagnosed in the United States, that's $16 million per year that we're spending. And if 1/3 of those patients had 3 scans per year, that's $26 or almost $27 million per year. That's being used without any known benefit. And so I think this is a real opportunity for us to have better behaviors in our practice. And so for ovarian cancer surveillance, symptom assessment continues to remain essential. Physical examination may be informative, but we do have limitations. And I think I didn't really mention it here, but there really is no role for cytology in ovarian cancer, and data has shown that. And I apologize for leaving it out. But unless a patient has her cervix less than situ, cytology can safely be eliminated. I think CA-125 is an early marker for recurrence. I struggle with CA-125 a little bit because I think there's no benefit to treating based on an elevated CA-125 alone. But I do think it helps guide us on monitoring patients. And I recognize that that's a little bit of a hypocrisy. So I think we need to flush out this. I think the best thing we can do is find better therapeutics where we can make asymptomatic recurrence our treatments more effective in those settings. And I do think imaging should be reserved for clinical indication. It's really hard to start imaging and then take it away from a patient. They don't understand that. So I think setting that standard early on is really important. So in 2012, the ASCO, which is one of our big cancer societies across the world, said we're going to challenge everybody to kind of come up with ways that we can assess the magnitude of cost of cancer care. And they actually engaged Society of Gynecologic Oncology as well as many other societies across the board. And they asked us to review our current practice patterns and look at ways to save cost without impacting oncologic outcomes. And so I was really excited because the Society of Gynecologic Oncology said, eliminate Pap tests for surveillance of women with a history of endometrial cancer. Do not perform colposcopy in patients treated with cervical cancer with Pap tests of low-grade squamous intraepithelial lesion or less, and avoid routine imaging for cancer surveillance for gynecologic malignancies. And so 3 of the 5 things that physicians should kind of question were based on our surveillance guidelines. So that was pretty exciting. And so these are the recommendations that we came up, and I won't belabor this because we've talked about this to some degree, but we did come up with these kind of tables. And I do think that these were published in 2011, and I think they already need to be updated and edited. But I do think it's really important that we communicate with other healthcare providers. If you have shared care with a family physician or internal medicine, make sure that they know who's responsible for surveillance, what that surveillance plan should include, because we want to avoid duplication of testing, especially testing that's not actually beneficial. And it's really important that insurance stakeholders know what to test for and what's not needed, so that the patients can have a better understanding of what their surveillance plan is going to entail. But there are lots of challenges. I've shown you data where we've seen people have just stuck with what they've known or what they've been doing for years. And I do think randomized controlled trials are the standard. And I'm so excited that we finally have one in endometrial cancer. But I do think we need to incorporate this into therapeutic trials moving forward. It is cost prohibitive. The TOTEM trial was a really expensive trial to run, but I think it's going to actually end up being so cost saving in the long run. They're also really resource intensive. And we know there's always a slow change or slow adoption to change practice. And this is because of anecdotal experience. I've heard someone say, well, I did a Pap test one time and it picked up that cancer, so now I'm just going to do it all the time. And so it gets hard to break out of these bad habits. I think one of the most pressing things is patient demands. It's not uncommon that I have patients almost arguing with me about their surveillance practices and, wanting a CT scan or wanting additional tests that may have no value for them. This could be like the CA-125 in the endometrial cancer patient. And then fear of lawsuits. We know that when a patient does recur, they may argue, oh, well, I didn't have X, Y, or Z done. So we really need to use our practice, the data we have to inform our practice and educate patients and make sure they understand that there's no value to these. That doesn't mean that the cancer won't come back. We just haven't been able to impact their survival. And I do think we need to start advocating for surveillance recommendations to be part of clinical trials so we can study this in prospective fashions moving forward. So I mentioned bloodletting in the beginning, and I want to come back to it. So with research, we've found that there is actually benefit of bloodletting. They've renamed it now phlebotomy, but in the treatment of specific diseases. So hemochromatosis, polycythemia actually have a lot of benefit, and this is the standard treatment. And there have been advances where we can now do this safely, and it's done under a controlled setting where it minimizes complications. So it just reminds us that practice should always be changing. And just because something is done doesn't mean it's not useful. It just needs to be studied and done in the right settings. And I want to say the same thing for surveillance. The story doesn't end here. We need to continue to evaluate for best practices. Maybe finding better tumor markers or better tests may actually help us determine which patients are, which strategies for surveillance are best. Advances in imaging may also be informative, but I really think the real crux of surveillance is going to be impacted by improved therapies. If we can make therapies better that have impact on patients at earlier timeframes, that's where we're going to really see our difference. And I will always argue, practice should always be changing. We should never be stagnant. We should always be looking to make our treatments and our follow-up surveillance practices better. So I'd like to thank you for your attention and just state what a true honor it is to be here with you today.
Ritu, thank you very much on a brilliant presentation. We have some extra space for question and answers, and I would like to start in almost in every single disease, you have a slide showing no benefit in survival, for every single disease. How do you cope with, if there is no any benefit in survival or even in relapse rate, why we still doing follow-up?
Yeah, I think that is the key question, right? I do think that symptoms and recurrence, we do need to treat our patients when they have the recurrences. But what the point is that doing these routine surveillance tests without data has never been shown to impact survival. Once the patient has true recurrence, symptoms, that's when we can make the difference. But I struggle with this. I actually think what we need to do is counsel patients on symptoms and make sure they have easy access to getting back to us, right? So just point of care access. And that's how we can help impact them and improve their outcomes. But you're exactly right. And this is why I always say that we need to continue to do clinical trials and understand how we can make therapies better and how we can do this at earlier standpoints. I didn't mention it here, but if we catch patients earlier and they're better candidates for exenteration or maybe something that's not as morbid, we might be making an impact, but we haven't been able to demonstrate that. So I struggle with this a lot. And you're right, you could say, let's not do any follow-up for these patients. You just come back to us when you have symptoms, and we probably will have similar outcomes in survival.
Do you consider of value to inform the patient at the beginning of the treatment that in the follow-ups, you will just perform interrogatory and physical exam rather than tests, pap smears, imaging, etc.?
I do. I do what I call a survivorship visit with them. And I tell them about it kind of early on. I say, let's focus on treatment right now. And once you finish treatment, we'll get kind of a new baseline scan. That's like your new post-treatment scan. And then after that, we do a surveillance or a survivorship visit where we talk about the symptoms. So we have just like it's usually 30 minutes, dedicated time to talk about what symptoms they need to look for, what testing we're going to do for them and why, what testing we're not going to do for them and also why, and how they access us if they have any problems. I also do ask them to make sure that their other doctors aren't ordering tests for surveillance of that cancer, because I think that can kind of muddy the waters a little bit. And so I let them know that, I'm responsible for the test that I order. The other doctors are responsible for the tests that they order. So make sure that we're in sync with those. So I do tell them early on, and I do get some patients who ask a lot of questions about it, but most patients are actually very like, this makes sense. I understand this. Let's move forward.
Ritu, the paper you have written in 2017, it is a classic for fellows.
Well, thank you.
It's really clear that there's no need for asking pap smear in endometrial cancer, just one pap smear in cervical cancer, etc., etc. The question is, in countries like Colombia, there are many actors surrounding the patient's care. So if you don't ask for the pap smear or CAT scan, the patient will come with the results asked for medical oncologists, even radiotherapists, because they don't know this information. How do you manage this with the rest of your team not being gynecologic oncologists, with medical oncologists or radiotherapists? Have you socialized this information with them?
Yeah, so when we do the surveillance visits, I actually take those tables and I put them in the note, and then I send it to the other providers. I also make sure the patient understands, I'm the one who's going to be ordering the test for your follow-up. So make sure that your other doctors are not, so that they understand. And oftentimes I'll have the patients tell other doctors like, oh, that's not part of my monitoring. It does happen on occasion, or if a patient gets a CT scan for another reason, I do always want to see it. Like, I'm not going to ignore information that's there, but it's a constant challenge. And I have medical oncologists that I work with today that are still getting CT scans every 3 months on patients who had ovarian cancer, 4 or 5 years ago. It makes me crazy. So it's a continued battle, but telling the patient, helping them understand. I also let them know the risk of these tests, and we didn't talk about it. And they're low risk, but getting CT scans, there's radiation exposure, there's IV contrast exposure. It's time intensive. There's the findings of completely unrelated events that might then result in unnecessary interventions. So I think it's a constant issue. I don't think there's ever going to be a time where a day passes where I don't have the inappropriate test that's ordered, or a patient that's undergone one. But I just keep trying to explain and help. And then when a doctor does order it, I usually send that doctor a message saying, hey, thank you for your care of this patient. Just so you know, for ovarian cancer, these are our surveillance practices, and that sometimes helps.
Okay, thank you, Ritu. We have a question from Juan Carlos Gut.
Tenemos dos en el chat y también dos que levantaron la mano.
Juan Carlos.
Si quieres, pues entonces primero los que levantaron la mano y luego los del chat. Hay dos preguntas en el chat.
Juan Carlos, ¿quieres hacer la pregunta en español, en inglés?
Si quieres, toma las del chat. Están en el chat. Juan Lalinde.
Ritu, es que la de la Linde creo que ya la respondió Ritu en la charla.
Y la de la doctora Angélica Fletcher.
If a patient in surveillance for cervical cancer has an annual cytology positive for ascus or low-grade lesion, but clinical examination is negative, at what interval of time would you recommend to repeat the pap smear, since immediate colposcopy is not recommended? Next year,
I would do it.
months?
I would do it in a year. I would just limit it to once a year, but I do tell the patient to look for symptoms. Yeah.
Okay, perfect. Asociación Colombiana, ¿quién está? Jaime.
Jaime.
Sí, yo, gracias. Dr. Salani, up to what point of cost effectiveness follow-up and paraclinical test or imaging are justified by the sense of tranquility that it offers to patients that feels that someone's watching and something's being made? What do you think?
Yeah, I don't know. I don't know the answer to that. That's too good of a question. The struggle with this, I think having the patient understand, the role and the purpose of surveillance is probably the most important. And I think that's one of the nice things about the visits is that they do feel like you're, watching them and talking to them and assessing them. So they're not being ignored, their cancer is not being ignored, and you're focusing on the important things for them. But I agree, I have a lot of patients, and I've had patients who recur and said, oh, if you had gotten a CT scan, would this have been picked up sooner? And there's just no answer to those questions, right?
Thank you, Ritu. Juan Carlos Guerra, ¿quieres hacer tu pregunta a la doctora Ritu?
Está sin sonido, doctor Juan Carlos.
Está sin sonido, Juan Carlos.
Entonces, el doctor Gilberto.
Doctor Martínez, proceda por favor con su pregunta a la doctora Ritu.
Gracias, buenas noches. No, realmente muy complacido con la conferencia de la doctora. Excelente el tema, porque definitivamente esto ha sido motivo de muchas discusiones a través de los años y no de ahora, de mucho tiempo atrás, justamente por la falta de información, la falta de estudios. Pero bueno, en los últimos 4 años los japoneses nos han enseñado mucho con sus estudios de intensidad frente a los estudios de seguimiento rutinarios. Y obviamente la información es la dada por la doctora. Definitivamente no hay que hacer tanta cosa como la hemos estado haciendo a través de los años. Hay un fenómeno que se nos presenta en el ejercicio profesional y es el relacionado con el abordaje de los oncólogos clínicos. El oncólogo clínico casi que pocas veces o muy pocos examinan los pacientes, entonces compensan de pronto esta falla en el examen clínico ordenando para clínicos, y es algo que se ve desafortunadamente de manera rutinaria. No sé si en el ejercicio de su profesión allá mismo encuentra este fenómeno. Y lo otro que hemos observado últimamente es que definitivamente no debemos enfocarnos tanto en estos paraclínicos para detectar cosas que probablemente no vamos a conseguir con exámenes de imágenes costosos, en fin, sino que básicamente la manifestación va a ser en algún momento dado, especialmente en las pacientes que tienen factores de riesgo importantes. Hoy se han dividido básicamente las pacientes que tienen ganglios negativos versus las que tienen ganglios positivos. Estas de ganglios positivos eventualmente podrían para usted tener un mayor seguimiento frente a las demás. Esa es una pregunta. Y la otra es si definitivamente tenemos que enfocarnos más, como debería ser, en la sintomatología de los efectos secundarios de los tratamientos. Vale decir, la misma cirugía, los efectos de la radioterapia, el estado menopáusico en que quedan la mayoría de las pacientes. Es decir, hoy se le está dando mucha más importancia a ese tópico que al mismo seguimiento con tanta invasión de imágenes.
Have you heard the translation, Ritu?
No, it was glitchy for me, so I couldn't hear it. Sorry.
Okay. Dr. Martinez congratulates you on your presentation. Asks about the lack of physical exam for the part of medical oncologists, and they try to supply this deficiency asking for test. What is your perception on that first? Second, is there any group that could benefit from a most intensive follow-up such as those with nodal involvement, probably?
Yeah, thank you. And I should probably ask how many medical oncologists are on here before I answer that first question. I do think that you're right, that the CT scans may be a surrogate for physical examination, particularly for women with gynecologic cancers, where many of our recurrences are pelvic and they don't do pelvic examinations. So I do think that that's a very good point. Same thing with tumor markers to some degree. I've never actually explored that, and it would be interesting to look at, how that translates in surveillance practices. So that's actually a really great thought. I've never thought about that. The second question was what again? I'm sorry, Renee, I forgot.
If those patients with nodal involvement have a more extensive or a different kind of follow-up.
Yeah, I don't know that we can recommend anything right now. And I do think there's some physician-patient discretion on how you would follow those patients, because we know those patients may not, if they have high risk of nodal disease or recurrence, they may not have symptoms. They may not have exam findings. So I think that that's something that may warrant it. I don't have any data to say, yes, those are the higher risk patients, but I think you're right that those are probably the patients who imaging may make the difference in. It may be worth going to some prospective studies, the clinical trials that were done where they do constant, imaging routinely and separating out those patients and looking at them further. So I think that those are both excellent questions, and I'm sorry I don't have a good answer for you, but I thank you so much for giving me some new ideas.
Juan Carlos Guerra, ¿quieres hacer tu pregunta?
Tenemos una en el chat, René, que preguntan Jorge Lazo. Sí.
Do you think that NCCN guidelines will make changes in a short period of time?
Yeah, so I'm proud to say that the NCCN guideline actually uses our paper for their recommendations. And our papers are actually, even though they were based on retrospective studies, are actually completely consistent with the TOTEM study. So I think that they may, update them to include that reference, but I think that they'll stay the same. Otherwise, they're pretty similar. I did talk about vulvar cancer today, just in the interest of time. That's one where there's a little bit of, they recommend like ultrasounds for the groins if there's sentinel nodes done. And I think that's actually good practice. I think that's kind of to your point earlier, Dr. Martinez, that, maybe there are patients who are higher risk that we should surveil differently. So vulvar cancer, which is one of our most rare cancers, actually has a better strategy. So I think that there's still lots of opportunities there, but I think the NCCN guideline will probably update to the reference, but the recommendations will probably be very similar.
Okay, Ritu, thank you. We are almost on time. I would like to let you know that we have more than 100 people
I see that. That's amazing. Thank you, everyone.
That's amazing. It's because of you. Thank you so
No,
much.
I think this is, I asked if I could be invited to these monthly. This seems like a really great conference. So
Ritu,
Okay.
in Colombia, it's not rare to see patients attending for surveillance after 10, 12, 15, 20 years after have finished their treatment, coming from far regions, poor regions, transportation costs, etc. How long should we follow up those patients?
that's a great question. And so when we looked at the data, it looks like, almost all recurrences occur within 3 years, but we kind of wanted a buffer. And so we did 5 years as kind of our recommendations. After 5 years, we just do yearly evaluations, and that's just like a well woman examination. So, physical examination, symptoms, and, they always have a point of contact. So if they ever develop an issue, they can always reach out to us sooner. But after that, we also say, if you want to see your, local doctor, that's perfectly fine too.
These yearly visits can be run by gynecologic oncologists, or should be a nurse or a medical doctor or gynecologic oncologist?
I think any of the above. I think if you're, depending on what your practice is, we have nurse practitioners and PAs, and that's oftentimes where we'll transition those patients, usually sometimes even after 3 years for low risk patients, we'll transition into them, or just say, you're traveling far to come to us, go ahead and see your local gynecologist. You always have a line to us if you have a problem or issue, but you don't need this kind of intensive surveillance. But someone who can do a pelvic examination.
Okay, perfect. Thank you very much, Ritu. We enjoyed a lot your presentation. I think it's really, really necessary to know and to spread it among our colleagues. I'll let the word to Doctora Clemencia Lucrecia Mojica in order to close the session.
Okay, thank you, Dr. Ritu. It was very, very, very nice, your speech, and I think we all learned a lot, and maybe we will follow everything, and maybe in some years we will tell you, Ritu, we really are not doing all this pap smears, and we've stopped doing CT scans and everything, but it's difficult. I'm with the other medical doctors that are seeing the patients, and maybe even with us. He would say, well, why don't I even ask for one exam? No, it's difficult, but you are really amazing. So all these things you're telling us, and this new work that is you mentioned about endometrial cancer, this perspective, and I don't remember the name of the
totem trial.
Totem trial. Okay, so that's it's prospective trial. So it's even major works, and it's recent. So it really should make an impact on all of us. And thank you again. And we will be telling you of our following webinar, so you can be with us.
Wonderful. Thank you so much. Thank you for
muchas gracias. Muchas gracias a todos por asistir, y les estaremos informando de la próxima conferencia el 21 de septiembre. Será sobre tratamiento de recidiva en cáncer de cuello uterino. Hasta luego. Gracias, René. Gracias a todos.
Buenas noches.
Chao, chao.